Hello and welcome to today's episode of the Pediatric Consult. I'm Dr. Paul Bunch, a pediatrician in the greater Cincinnati area and your host for today. I'm in the studio with Dr. Adam Powell and Katie Bloomfield, both from the Heart Institute at Cincinnati Children's Hospital. Today's discussion is on chest pain, which is a very common reason for visits in my office with a wide differential. Today we'll be specifically discussing cardiac versus non-cardiac chest pain. First of all, Dr. Powell, Katie, welcome. Thanks for joining us today. For our listeners, could you tell us a little bit about yourselves, your clinical interests, some of your background?
Thank you for inviting us. This is wonderful to sit here and talk about this really important topic. I am born and raised in South Carolina. I've lived in Cincinnati the past 8 years, but you'll occasionally hear some southern drawl come out if anybody's listening from down south. I've been in Cincinnati for 8 years. I did my fellowship training here. I am the main exercise cardiologist in the exercise lab, and I'm also the medical director of ambulatory cardiology. And so I see a lot of kids, a lot of young athletes with chest pain who are both have cardiac causes as well as the more reassuring non-cardiac causes. So I'm excited to talk a little bit later about all those.
And thank you for having me. I'm Katie Bloomfield. I am a nurse here, born and raised in Cincinnati. I graduated from Xavier University. Been a nurse for 18 years, showing my age there. And I've been in pediatric cardiology in the Heart Institute for about 5 years now. I work with Dr. Sean Lane in a coronary artery clinic, and I work closely with Dr. Powell too. So coronary artery disease in pediatrics has been my main interest since I've been in the Heart Institute. And I'm a mom and I have 2 kids.
Great. Thank you guys both for joining us. So let's first talk about just the incidence of chest pain in pediatric patients. Do we know roughly how many kids present just to all offices or to the ED or to your clinics with chest pain in a given year?
Chest pain is very common in pediatric cardiology. It's the second most common cause for a new patient to be referred to us after murmurs. Thankfully, though, cardiac causes of chest pain only happen less than 1% of the time in those that we see in clinic. Even in patients who go to the ER, who present to a pediatric ER with chest pain, acute chest pain, they have a cardiac cause in less than 5% of the time. So it's very uncommon for us to find a cardiac cause, but they're out there, and we'll talk about that.
Yeah. When you're seeing these patients either in our office or in the ED, what is their perception? What do they feel like's happening? What are their fears that they'll express to us?
I feel like when they present to our clinic, both the parents and the kids are just scared that there's something wrong with their heart. I think that's the first thing that they go to, and they are coming for reassurance that there's not something specifically with their heart that's wrong. But I think sometimes they have a hard time describing what they're feeling. So then that's our job to tease out the details of the episodes that they're experiencing.
And all these people have seen the news. I mean, they know what's going on with Bronny James. They watch Monday Night Football. They saw what happened to Damar Hamlin. And so everybody's just terrified that any pain in any of the square around their upper chest has got to be the heart pain. And so often they are super scared and super nervous, whether it's a 5-year-old, a 15-year-old, a 23-year-old. But a 23-year-old expresses themselves different than a 15-year-old, different than a 5-year-old. And that's kind of where we kind of tease them this stuff out based on age and kind of our experience with seeing these kids.
And you said like less than 1% truly have a cardiac origin. What other big buckets of diagnosis categories do we see?
Costochondritis is a big one that we see in clinic. Especially, I talk to parents on the phone all the time, and they'll call with chest pain symptoms. And, pediatrics, they're active in sports and they're rapidly growing. And that's something that I talk about with parents frequently, both that have congenital heart disease or they're otherwise healthy. I think stress and anxiety is one that a lot of kids have, and they experience chest pain, but they don't really know how to express what they're feeling or why they're feeling it. What am I missing? Other non-cardiac?
Pulmonary causes of chest pain. And then stomach, GI type causes of chest pain. We know reflux, you can have some kind of referred pain in your chest. because your esophagus is going past there, and the child, especially the young child, has a hard time understanding where the stomach is versus where the heart is, and the fact that stomach pain could actually, feel like chest pain, feel like heart pain, but it's really not.
And it's a pretty short distance in a little kid, too.
It is.
So, we learned first week of medical school or training that, the first and most important part of the evaluation is getting a history. So what are some key questions that we should be asking to any patient that comes in with complaints of chest pain?
I think as far as the episodes of chest pain goes, we like to know if this is obviously a new thing that they're experiencing or if it's a reoccurring thing and how often. A lot of times when I talk to parents, I encourage them to keep a diary of the episodes so that they can write down where is the chest pain occurring, what does it feel like to the kid, is it sharp, is it dull, does it feel like pressure, how long is it lasting, and what are the most important thing we look for is what are they doing when they're experiencing the chest pain.
Yeah, I agree. I mean, reproducible versus non-reproducible. If it's reproducible chest pain, by definition, it's not going to be cardiac.
On exam, you mean?
Or history.
Okay.
If the patient can reproduce the pain, whether through deep inspiration, whether through their own palpation, stretching, movement, lying a certain way, position changes, whether it gets better or worse with drinking water, with eating food, if the patient can do something to modify the chest pain, short of I stop exercising and it goes away, then it's not cardiac chest pain. On the flip side, if you have chest pain that's only during activity, and it's only during strenuous activity, it gets worse towards the tail end when you're really tired. And the only way it gets better is if you stop doing that activity and nothing else makes it better, nothing else makes it worse. Nuts. I mean, that's probably one of those kids we probably should see, even though, the chance of us finding something is pretty low, but that's a little bit more concerning. The other thing that's a major red flag is any kid that has syncope during exercise. That's definitely a hard stop for us, and we absolutely want to see that kid. We probably won't even clear them to play sports until we see them either. Mm-hmm. The kid who has chest pain during exercise, that, as a pediatrician, you're generally pretty reassured. It sounds pretty reproducible based on your history. I don't necessarily think they need to be restricted before sending them to see us, especially if you generally feel pretty reassured. But I think a referral is still good, if nothing else, for parents' peace of mind.
Mm-hmm. I would agree.
Okay. And anything else in the patient's individual medical history that would raise red flags or would get you more concerned? Other associated conditions, things like family history even, anything else like that?
I think family history is important. We always ask about first-line relatives, any history of cardiomyopathy, any deaths, sudden deaths before the age of 50, history of pulmonary hypertension or family members with pacemakers, defibrillators, arrhythmias is important to know.
I'll also ask, are there any young people who died in your family from kind of unexplained circumstances? The person who died in a car accident on a flat road in the plains on a sunny day. The person who drowned, even though they knew how to swim. Because that could be an underlying cardiac etiology, but they happened to be someplace else when it happened. And then the presence of a pacemaker or defibrillator, especially if it was placed before the age of 50.
In a family member?
In a family member, correct.
Okay.
Correct.
All right. And then on our physical exam, any particular maneuvers we should be doing, anything that would, again, raise our suspicion level for a cardiac cause?
The main thing would be just a nice, thorough cardiac exam. Listening to the person, listening to the patient while they're sitting up, listening in the 4 major spots, doing a pulmonary exam, lying down, especially if you hear a murmur, to see if the flow of the murmur, the volume, the character changes from sitting versus supine. Again, listening to those 4 spots. And then probably the things that I do that are the highest yield, both in finding the bad things as well as being reassured. One is palpation of the chest, specifically the sternal margins, because oftentimes in costochondritis, you can touch the origin of that intercostal muscle and cause pain. And if that happens and the history is reassuring and the family history is reassuring, then you're done. And the other thing that helps me sleep at night, at least, is I do a subxiphoid palpation to check for right ventricular heave. Sometimes in kids who have idiopathic pulmonary hypertension, which is a really terrible diagnosis that often presents with vague symptoms of vasovagal syncope or chest pain, sometimes the first sign that they have it is either with a murmur from tricuspid regurgitation or an RV lift, an RV heave, which you can feel in the subxiphoid process. Upper and lower extremity pulses, that should be in all cardiac exams, check for hepatomegaly. But those are probably the main things I'd be looking for.
Okay. And we're recording this in July. We're getting ready to get into fall sports season. These kids are going to be coming in, these, adolescents, even younger athletes who they're getting ready to kick off practices. Their big question is, can I go to practice tonight? Can I go tomorrow? Or maybe their parents' question is, should I send them to practice? We'll talk about those kids that we're going to send on for further testing, but is there a group of kids that you would clear almost immediately to go back to practice? Or even if you're going to be getting an EKG or something, that you would still allow them to some level of physical activity?
Reproducible chest pain. Okay. Reproducible on exam, reproducible by history. But you have a nervous parent that just says, oh, I don't know. I don't want my kid to be like Damar Hamlin. For that one, I think that one you can absolutely clear. And I think any kind of chest pain that's happening at exercise and at rest, and it's the same quality, even if it's not reproducible based on history, chest pain at rest is usually not cardiac. It's usually something else. And so I think that's another kid that I would let them continue to exercise and let them participate in their sport. I think the ones I wouldn't would be syncope during exercise, or like we talked about before, that chest pain only during strenuous exercise, only improves with rest, no other modifying factors.
Okay. And, in our primary care office, what would you recommend as a first line? Let's say they have, some concerning symptoms, some things that are, maybe more reassuring, but you're on the fence. Are there any tests, evaluations, things that we can order or do before we send them to cardiology that would be helpful?
I mean, I'm a little bit of a carpenter. I have a hammer. I'm going to use it. So, EKG. I think EKG, it's cheap, it's easy, it's portable. I was in the Air Force for 7 years before doing cardiology fellowship, and I was stationed in a tiny little Air Force base in country South Carolina where I was a small town doc. I did my own EKGs because the Children's Hospital is 2.5 hours away, and I didn't want the kids to drive that far. They're easy to do. And then if you get one that's even remotely questionable, then you commit to sending them. But if you get one that's normal, totally normal, and the history is reassuring and the family history is reassuring, then you generally feel better.
And then what about exercise tests, graded exercise challenges, those types of things? Do you find those to be beneficial for pediatricians to order? How often do you order them yourselves?
That's very much my shtick, is exercise testing. I love exercise testing. Before I even started doing this, I just got off an hour meeting with someone in Texas talking about how we should do more exercise testing, exercise studies. In this population, though, it's probably better to let the cardiologist order it. It's so hard to find the cardiac causes of chest pain, and oftentimes we need multiple different tests. The specificity and sensitivity of these tests are, in isolation, often subpar. And so I think if you're concerned enough to where you're thinking we should get an exercise test, I think just refer to cardiology. The other nice thing about referring directly to cardiology is that, if we are concerned that this is a cardiac cause, we can often get that test scheduled a little bit quicker.
And just to speak to that, in my clinics, if we see a patient with chest pain and they're concerned and we do an echo and they see something that's concerning, or they want to order an exercise test, a lot of times we can do it the same day as the visit if the family's willing to stay a little bit longer.
So one question I've been getting a lot lately is some high schools are offering pre-sports echocardiograms that a company comes to their high school and is offering these screening tests. What value is there in those?
Yeah, I'm generally not a very big fan of those. I think before we pose this, I used a different term for what those are. I generally just not very helpful. It's a very limited echo. It's about 3 to 4 clips that are about 1 to 2 seconds long. A full echo that we do is about 120 to 150 clips, with each clip being 3 to 5 seconds long. So it's very limited. It's really okay at detecting. It's okay to fine for picking up the most common cause of sudden cardiac death in young children, which is hypertrophic cardiomyopathy. It will not pick up anomalous coronary arteries, which Katie's shaking her hand. She also doesn't like these very much.
No, I do not.
And it does not pick up the number 3 most common cause, which is myocarditis. Doesn't pick up the number 4 most common cause, which is arrhythmias. Even if you add a baseline EKG to that, it's not going to pick up some of the exercise-induced arrhythmias. And so it's very limited. I think it can provide parents with a false sense of security because it comes back normal. Or the thing that we see often is they find an incidentaloma and they come to see cardiology for something that would have never bothered them, but now they have to see us for the rest of their life for something that's totally inconsequential.
How often, Katie, are you fielding calls on this?
We get a decent amount of calls about it, and I do agree with Dr. Powell. I think most of the time it induces panic in parents about something that probably they would have never known if they do find something and would never have caused the child any problem. And to speak to what he said about finding something hypertrophic cardiomyopathy, you could maybe find on that echo, but any coronary anomalies, we have some of the best sonographers, and even sometimes they have issues visualizing the coronaries when they're in clinic. So I feel like even if they found that to be abnormal, we're going to redo it anyway.
Okay. So, of course, parents are going to do what parents are going to do, but you would say we should not be advocating for these or having parents going in with a open eyes as far as the limitations of these tests.
Correct.
Yeah.
Correct. I mean, screening is fantastic in principle, and we need to come up with better screening tools to detect causes of sudden cardiac arrest. But a lot of the things that we're doing right now just aren't quite ready for prime time yet.
Okay. So if we have one of those kids who has, chest pain that is only with strenuous exercise or syncope with exercise, we're going to refer them to you. They're going to go see you guys. For those kids who don't meet those criteria, are there any interventions that we can do or treatments that we can start on an outpatient basis other than reassurance and clearing them from a cardiac standpoint?
From a nursing perspective, if we have patients that call with costochondritis, some of our things that we recommend to families is ibuprofen every 6 hours, which is probably something that you guys do as well.
Mm-hmm.
Ice packs, heat packs for alternating 20 minutes or so can sometimes help. I tell families they can do stretches to help loosen up some of those muscles. What are some other things?
I think a lot of it also just depends on what is the underlying cause of the musculoskeletal chest pain. If you can locate the specific muscle or the specific movement pattern that irritates that muscle, then you can treat it like any other soft tissue injury. You rehabilitate that muscle, you fix that movement pattern. In teenagers in particular, they have a lot of costochondritis because they lean forward on their phone, their posture stinks, their shoulders are forward, and whenever they sit up, they're just not, their muscles aren't used to being in a neutral position. And so those patients can also be helped with, especially if they're having chest pain that's lasting for more than a few weeks, more than a few months, physical therapy can sometimes help with chest strengthening, back strengthening activities, as well as working with posture. And then exercise. A lot of these kids are having chest pain because they're not doing a lot. And like any muscle, if you don't use it, it gets weak and it's easier to get injured. And so, doing some light aerobic exercise, some light resistance work can also help.
Sometimes age of the patient is going to lead us down one path versus another. Are there any differences in causes of chest pain from younger kids compared to older kids?
Yes, younger kids, they can have some of these muscle injuries that teenagers can have, but frankly, younger kids aren't doing varsity level sports and strenuous activities. Their causes can be just kind of transient muscle spasms, kind of the things that can cause precordial catch, where those intercostals spasm down, they squeeze, it hurts really bad, it takes their breath away, it's terrifying because the kid starts crying, it makes the parent nervous, and then it makes the parent gets nervous, the kid gets more nervous, and it starts this vicious cycle. And so I think that's a very common cause. I think the other common cause are growing pains. You know, we often think of growing pains with the legs and stuff, but we also see that in the chest as well.
Yeah.
And with precordial catch syndrome, that's something I do feel like I see in my office quite often, but sometimes I feel like the parents aren't buying what I'm selling on that. What features of their symptoms would lead you to a diagnosis of precordial catch versus something else?
Probably just very quick, sharp pain and no other explanation.
Usually at rest.
Yeah, at rest.
Usually at rest.
Or rest or exercise is what I've seen
And it's
typically.
fast. It's just such a quick
Sudden,
thing.
yeah.
I mean, it lasts for like just a few seconds, and by the time they get the ibuprofen, they're not having pain anymore.
So we can reassure the parents that if it's that quick, if it's 5 seconds or less, or maybe up to a minute, depending on what the kid says, but typically what I've seen is a few seconds.
Correct.
That's pretty reassuring for the parents.
Absolutely.
Yeah.
Good.
Yeah.
Are there any kids that we'd be seeing in our office that you'd recommend referring directly to the ED? Are there any circumstances where that would happen?
Very rarely. Very, very rarely. I mean, I think, only if you see a kid who's having signs of end organ dysfunction. So I just trying to think through some possibilities. I think if you have a kid who has active myocarditis, distant heart sounds, hypotension, tachycardia, hepatosplenomegaly, I think that kid could go. If you have a kid with coarctation of the aorta, say there's a 20, 30, 40 millimeter of blood pressure difference between the upper and the lower extremities, or they have absent femoral pulses, I think that's very reasonable to either send to the ER or just call the cardiologist directly to say, hey, I have this kid. I think they have coarctation. What would you like me to do with them? Where's the best place for this child to get care?
And then, of course, that worst outcome, the kid who truly is having cardiac chest pain, goes into sudden cardiac arrest. In the community, AEDs are becoming more and more prevalent. Are there other things that we can be doing to advocate for AEDs or for just awareness in the community?
Absolutely. I think awareness is the number one thing that we can do, especially as our community pediatricians. So I volunteer. I'm the medical director for an organization called Project Adam, which helps put AEDs in schools as well as helps schools with their emergency response plans, with their response teams. And I think since I've been doing that, it's just amazing with my own kids how many times I go to a gym or soccer field, baseball field or something, and there's nothing. There's no signs, there's no AED. And so I think just identifying those gaps as the pediatrician first and foremost, I think that goes a very long way. There are so many wonderful organizations that are working hard to improve our responsiveness with sudden cardiac arrest, especially in light of our screening not being great. And so I think identifying that and then finding that partner organization, whether it's Project Adam, the American Heart Association, the NFL has their Post Lamar Hamlin initiative that's really been quite successful. I think having the AED, making sure it's functional, it has batteries, it's charged, making sure that there's pads and non-expired pads, and then some of the simple stuff. Is the AED someplace where people can find it when they need it? Is there a sign? If it's in a school or hardened facility, are there people who have been identified to be tasked with activating the code scenario, getting the AED, directing first responders to where the event's happening? Have CPR training, PALS training if you're in a pediatrics office. And so I think those simple things go a long way. I mean, we've had really heartbreaking situations here in Cincinnati in which there can be an event in a school, in the gym. There can even be a cardiologist present next door outside. But because the AED is locked in a door and because no one notified anybody, the cardiologist had no idea. No, people could see the AED, they couldn't get it, and the child ultimately expired. And so I think some of those simple things that sound simple, but it goes a long way when there unfortunately is an episode of sudden cardiac arrest, and when that happens, it's nice not to have to worry about some of those seemingly simple things.
Mm-hmm. And, as a medical provider, sometimes the way we view an environment might be different. So if we're somewhere where we think there could be an AED here, there should be an AED here, a soccer field, a baseball field, a gym, are there places we can contact to start that process?
Absolutely. There's a ton. The American Heart Association, on their website, they have a nice link to a bunch of organizations similar to Project Adam that are going to help out with this. Locally, there's another organization called Take 10, which focuses on sudden cardiac arrest training and stop the bleed for coaches of these kind of local school organizations. And even breaking it down to simple stuff. There's grants to be had in which people are begging to give money to people to give AEDs to schools. Firehouse Subs has a really nice, effective grant program. It's just something that's kind of simple. There's the Joel Cornett Foundation, who's a former Butler basketball player who died in his late 20s from coronary artery disease. They have a foundation in which they're really trying to give AEDs and doing great work to try to help protect the community. And so there's a lot of people that want to help. It's really right now we just need to identify those gaps and find partners who's willing to help us kind of fill in the holes in our coverage for sudden cardiac arrest.
So our listeners have their marching orders. They need to be those advocates. We've covered a lot of somatic causes of chest pain, whether it is cardiac or non-cardiac. What about mental health? How does that play into perceiving chest pain, how they respond to it, how we address it?
I feel like a lot of the patients, not a lot of the patients that we see, but there are some patients that we see where there could be some anxiety, stress related to the pain that the child's experiencing, and it's not something that is, I think, coming to mind to parents. It would be the number one cause that their child's experiencing it. So I think that's something in the pediatrician office that could be teased out before they come to see cardiology, if that could be one of the causes, a contributing cause to the pain that the child's experiencing, and whether it be stress at school or stress at home. It's a thing that a lot of kids can't describe that they're feeling. And even if they still get referred to cardiology, I think it's a nice topic this could be one of the other causes before they come and see the cardiologist. I think this is probably non-cardiac, and these are the other things that might be contributing to it, just to have it in the back of the parent's mind.
And there's common themes, chest pain that began a month or so after a family member died of a heart attack, chest pain that's only in school, chest pain that happened after they started an antidepressant, after they started anti-anxiety medicine. Sometimes it can be side effects of the medicine. Oftentimes it's side effect of the underlying anxiety, underlying depression. And then the other thing that can be is sometimes they can have chest wall pain, musculoskeletal chest pain, and it makes them anxious, which makes them notice the chest pain more, which makes them more anxious, and they just get stuck in that feedback loop too. But before COVID, I thought anxiety and stress was probably the second most common cause of chest pain, especially in teenagers. I think it's probably tied for first now. It is very, very common. It feels like almost all the kids we see have at least some component of anxiety, some component of mental health distress.
And are there any resources you guys have found that are helpful for that aspect of chest pain?
Those are hard because a lot of times those patients just need to hear from a cardiologist that they're okay, that they're not going to die, and that this pain isn't dangerous. And hopefully, they can hear that from the pediatrician who, ideally they've been seeing for quite a while. They have a medical home they have a trust, they have rapport with, and hopefully the pediatrician can reassure them, plus or minus an EKG in that visit. Other resources, counseling, mindfulness training. There are some really nice apps like the Calm app that can kind of teach meditation and mindfulness type trainings, stress reduction techniques. Our friends in Europe do a lot of yoga meditation for this as well.
Well, Adam, Katie, thank you so much for your time and expertise today. For our listeners, a reminder that today's episode is available for CME credit. You can find the link for that in the show notes. Also, today's discussion was guided by the Cincinnati Children's Community Practice Support Tool. You can find that on the cincinnatichildrens.org website. Adam, Katie, thank you again. I hope everyone has a great rest of their day.
Thank you for having us.
Thank you, Paul.